Good morning, everyone. Today I'm here to present my topic on dental implants and implant related complications. So, to begin with, we all know that the replacement of teeth has been made easy with the evolution of dental implants because the traditional fixed partial dentures and removed partial dentures have many disadvantages, which includes the fixed partial dentures. We have to grind the natural teeth, whereas in removed partial denture, it is very inconvenient for the patient to maintain it. So, dental implants have revolutionized the tooth replacement and has successfully replaced the missing teeth. And over the years, there has been several modification in terms of the design of the implant surface and also in terms of the surgical treatment and prosthetic procedures, wherein it has gone digitalized for impression making and CBCT and all. So to begin with, I cannot skip Mr. Brainmark, who is the father of modern implantology. So, what did Brainmark came up with? He gave the term osseointegration. So, osseointegration is nothing but the direct structural and functional connection between the ordered living bone and the surface of a load-carrying implant. So, we need the implant to be completely osseointegrated with the host bone. That is, wherever we place the implant, we want it to be tightly fixed to the bone. So that term osseointegration is this direct structural and functional connection between your ordered living bone and the surface of an implant. How did he came up with this? Because he observed this process of osseointegration in a rabbit study wherein he used commercially pure titanium to treat the fractures of long rabbit, where he fractured the bone and placed this commercially pure titanium, wherein he observed bone formation around this titanium. So it was in 1950 he found this osseointegration. In 1965, the first patient has been tried with implant placement. And then around 1970s and 80s, long-term studies on the success of titanium implant therapy has been done. So how do we classify implants? Basically, implants are classified based on their implant geometry as endosteal implants, subperiosteal implants, and transmandibular implants. So what we do generally in regular clinical practice, in conventional cases, not in compromised cases, we use the endosseous implants, which includes your cylindrical, screw-shaped, and tapered design implants. Subperiosteal implants or custom frame implants that are based on the jawbones, whereas transmandibular implants include long posts and rods through ear that pass through your mandibles. So, implant surface characteristic. As I said previously, osseointegration is the major success, is considered as the success for implant therapy. It has to be completely osseointegrated. So, to increase the osseointegration and to increase the surface area of implant to attain osseointegration, we have many implant surface treatments, which includes additive procedures and subtractive procedures. Additive procedure include adding material and chemical to modify the surface structure and chemistry, which can be inorganic material coating or plasma spraying with hydroxyapatite and growth factors or some bone forming agents, which includes nowadays some drugs, even like metformin and simvastatin. So, subtractive process includes removing or altering the existing surface by machining, acid etching, and sandblasting. So all this are done in an aim to improve the surface area of your implant, thereby increasing the contact of the implant with the bone, enhancing the osseointegration. So what is how does healing happens around implant? Yeah, as with any healing, inflammation is the first step. After inflammation, blood flow will increase, and then the osteoprogenitor cell will migrate to the osteotomy site, which then differentiates to your osteoblast lineage cell, wherein the osteoblast will form the bone. So osseointegration, there is two types of two terms which I want you all to know, which is fibro-osseous integration and osseointegration. Osseointegration, as we all know, is the direct structural and functional connection between the bone and implant. When there is tissue, connected collagenous tissue between this implant and bone forms, it is called fibro-osseous integration. And this osseointegration is given another term by Meffert et al. As adaptive and biointegration. Then what all are the factors that affects osseointegration? I would like to start with implant stability. So what is implant stability? First is the primary stability that we check during the implant procedure. While insertion, after osteotomy site preparation, we give a talk to find implant stability that should be above 35 and till 70 Newton centimeter. So any movements exceeding 150 micrometer impairs your osteoblast differentiation, thereby affecting the bone formation and osseointegration. An obvious reason, my inflammation um, in more which is more than the normal inflammation that occurring in the healing will impair your osseointegration. And then bone quality. Coming to bone quality, of course, we take CBCT to know the bone quality, which is generally D1 of mandible, which is dense cortical bone has this D1, and posterior mandible is D2, and anterior of maxilla is D3, posterior maxilla is D4. Posterior maxilla is D4, which is because of its porous bone quality. So the ideal placement for implant would be D2 bone, that is your posterior mandible. So bone quality also decides the implant placement or implant success to some extent. So, and also the osteotomy site preparation has to be taken care of because adequate cooling is required to prevent overheating of the bone surface, which will affect the bone cells and cause necrosis. So the critical temperature, as we all know, is 47 degrees Celsius for bone. So cooling should be taken care of by the clinician and by the assistant. And surgical technique, proper surgical technique has to be curated previously in the pre-work of your case with the CBCT and mock-up and all, so that we do not compromise on any levels on the vascular supply to prevent it from better healing. So bone remodeling is that primary stability, which is achieved, as I said, at the time of placement, and early healing is during initial weeks where initial bone resorption occurs, and then secondary stability which are achieved over time, and long-term function which is implant resist occlusal force for many years once the osseo integration is completely achieved. So implant and tooth are different. Obviously, this is processes. Of course, it is a biocompatible. It is a biocompatible material. There is some difference that exists between implant and tooth. So the connection between tooth is the cementum and the pedial, where we don't have a cementum and the pedial in implant because it is tightly it is also integrated with the bone. And junction epithelium, it has immediate mucosum and basal lamella. Here, the junction film also has the immediate mucosum and basal lamella, and also lamina lucida, lamina densa, and sublamina lucida. Whereas the connective tissue in teeth, in natural teeth, is perpendicular to the tooth surface, whereas the connective tissue is parallel to the implant surface. Whereas biological width in normal natural teeth is 2.04, whereas in implant it is slightly higher, which is 3.08. Vascularity, as you all know, the natural teeth is highly vascular because of the pedial and the nerve, the vessels entering the pulp, so it is highly vascular compared to the implant. Probing depth is 2 to 3 mm in natural teeth, whereas in around implant is slightly higher, given a range of 2.5 to 5 mm. Bleeding on probing is a more reliable indicator for a risk of periodontal breakdown or gingivitis in tooth, whereas it is not that reliable in implant. So where do we indicate implant? It is very easy that we replace with partially dentulous or fully dentulous arches and patients with deformities, patients who are unable to wear the removal processes and have really adequate and good quality of bone for the placement of implant, and good general health and good oral hygiene patients who are willingly cooperative to go through this implant therapy. So, what are all the contraindication? As a contraindication, to be precise, there is this relative contraindication and absolute contraindication. So, diabetes is an relative contraindication. It is not an absolute contraindication. If the patient is controlled diabetic, we can place implant. If it is uncontrolled, then it is the absolute contraindication. Whereas chronic steroid therapy and high dose irradiation and smoking and alcohol abuse patients and pathological conditions of hard and soft tissue and previously untreated periodontal disease has to be taken care of before planning for implant therapy. So there is this one stage implant and two stage implant, wherein in one stage implant, after osteotomy, we place the implant along with the abutment. So there is no need for your second appointment to place abutment. This reduces your appointment time. Whereas in two-stage implants, after osteotomy site preparation, we place the implant, we place cover screw over it, we suture the tissues, and then we recall the patient after 3 or 4 months for healing clap placement. So this is the difference between one stage and two-stage implant. So advantage, as I said, patient management is simplified because second stage surgery is not necessary. Whereas in two-stage implant, where there is augmentation is required, we can do in two-stage implant because we have opened the flap and we can do the augmentation. And also this prevents the movement of the implant by the patient who may inadvertently chew because we are not going to place any attachments over the implant like as in the first one stage, we place an abutment that is fixed to the implant surface. So this will not affect the healing period. As I said, the stability in implant stability, any micro movements over than 150 micron, this will affect your initially healing. So this two-stage implant prevents this micro movement and will help in healing process. So these are the advantage of your one stage and two stage implants. So 1 minute. Coming to the complications, I would like to deal with implant related complication under these topics as surgical complication and due to placement and loading protocol and prosthetic or mechanical complication and aesthetic or phonetic complication related to augmentation procedure and biological complication. So what are all the surgical complication that might occur? So while surgery, if we don't plan the implant therapy properly in terms of CBCT, what do we see in CBCT? Of course, so we see for the anatomical structure and we plan the implant. So if we miss out this assessment, or if we have errors in this assessment, we might end up in neurosensory disturbance because there is this inferior alveolar canal. If we encroach this space of inferior alveolar canal, obviously the patient will land up with paresthesia and implant failure and implant malposition leading to a failure wherein you cannot place prosthesis and the general surgical complication which is hemorrhage and hematoma formation. So coming to the biological complication includes the inflammation and proliferation and dehiscence and recession. This and all has to deal with your microbial block and dehiscence and recessions are leading to your soft tissue parameters, which include the width of your keratinized tissue and peritonitis and bone loss. If there is microbes under your processes or crown and which lead to your periodontal breakdown, leading to implant failure and implant loss. These are all the biological complication and complication related to augmentation, autogenous bone grafting, harvesting, and guided regeneration and sinus augmentation. In all these cases, the bone, we have to procure the bone in autogenous bone graft from a site in intraoral or extraoral site, and that might result in delayed healing, or it cannot integrate with the into the site. So that might lead to your failure of implant therapy. So the complications due to placement and loading protocol, if you place immediate placement and immediate loading and immediate placement using flapless approach. So generally, we see the bone, we raise the flap, we see the bone, and we place. If we go for if we're not very confident enough, and if we go for a flapless approach, there might be a difference in implant positioning, which might land up in trouble. So sometimes an immediate placement and immediate loading, healing might not occur. So we have to properly plan the case. So coming to prosthetic and mechanical complication that can occur, which is screw loosening and fracture of restoration and implant fracture. Screw loosening is one of the most common implant related complication you might come across with the patient. Patient might be complaining of mobility, implant mobility, but we would have, oh God, this scared. We are really scared to approach this patient, but it would be just screw loosening and fracture of restoration and implant fracture or other prosthetic complication, which would require you to really remove the implant from the host bone. So aesthetic and phonetic complication related to aesthetic, it is the smile line or inadequate bone quality and quantity, implant positioning, and gingival tissue contour. Whereas phonetics with unusual palatal contours or thickness, increased thickness, be which might affect the phonetics of the patient, and space under and around this processes might also affect the phonetics. So how do we treat the peri-implant disease or peri-implantitis? It is given by Mr. Mobili and Lang, the protocol, which is when the probing depth is less than 3 mm and you do not see any plaque or bleeding on probing is negative, then you don't need any treatment. Probing depth is within 3, plaque is not there, bleeding is not there, no treatment, just follow up. If there is presence of plaque and BOP is positive, but probing depth is less than 3, even in this case, only the plaque and bleeding is present, do mechanical debridement and polishing. When the probing depth is 4 to 5 mm, then antiseptic cleansing with antimicrobials. Okay. Then, if it is more than 5 mm, but bleeding on probing positive, no bone loss, then follow the similar protocol as antiseptic cleaning. Whereas probing depth greater than 5 mm with BOP positive with bone loss less than 2 mm, you give systemic or local antibiotic therapy. If it is if probing depth is more than 5, BOP positive, bone loss more than 2 mm, resective or regenerative surgery has to be undertaken. So, to conclude this, I would say that careful diagnosis and treatment planning with diagnostic images being given that CBCT has revolutionized and made the surgical procedure a cakewalk for anybody. Any Tom, Dick, and Harry can do uh, implant surgery with in advancement in CBCT. So, a careful diagnosis and treatment planning along with use of diagnostic imaging and a thorough understanding of the anatomy, biology, and billing would give implant therapy a major success. So this completes my um, class. So thank you all for giving me this time. Thank you.